Hello everyone, I'm Mark Lugay, graduate student of Grand Canyon University. This presentation talks about tuberculosis, a microbial disease. In partial fulfillment of the requirements in Bio-525, concepts on medical microbiology. For us to learn about the disease and its pathogen, the following are the objectives. First, I'll be discussing the discovery and characteristics of Mycobacterium tuberculosis. Next, describe the taxonomy of M. tuberculosis. Third, explain the bacterial pathogenesis, or how does it cause infection. And last, give details on the epidemiology, or where it is prevalent and how does it spread, plus treatment and prevention of tuberculosis. Before the teaching learning process starts, this pre-assessment will check how much students know about the topic. This will help determine the appropriate method to teach and other interventions or adjustments to consider to maximize students' potential. The pre-assessment is a 5-item multiple choice quiz using Google Forms. So we were asked to write your last name and first name, then answer the five multiple choice questions. So that's the pre-assessment. So let's start. Tuberculosis is a contagious infectious disease, the term coined by Johann Lucas Schleien in 1834. This microbial disease is caused by Mycobacterium tuberculosis, discovered by German doctor Robert Koch in 1882. He successfully isolated the causative agent of tuberculosis by isolating the microbe using a solidified serum-based culture medium. His discovery was a significant contribution that could be diagnosed, treated, and prevented by one of the lethal diseases in human history. Mycobacterium tuberculosis is an obligate slender and non-motile, rod-shaped bacterium. The rods are 2 to 4 micrometers in length and zero point 0.2 to zero point 0.5 micrometers in width, where they grow slowly for 20-hour to 48-hour or longer generation time. And tuberculosis is capable of intracellular growth and sometimes forms filaments and tends to grow in clumps. And their growth appears mold-like structure, which is a basis for the genus name Mycobacterium, where myco means fungus. The cell wall structure of M. tuberculosis makes it unique among prokaryotes. This serves as a determinant of virulence for the bacterium. The cell wall complex contains peptidoglycan and three major lipid components: the mycolic acids, Hord factor, and WAX-D. The taxonomic classification of the microorganism belongs to the kingdom Bacteria, phylum Actinobacteria, subclass Actinobacteridae, order Actinomycetales, family Mycobacteriaceae, genus Mycobacterium, and the species is Mycobacterium tuberculosis. How does Mycobacterium tuberculosis cause infection? M. tuberculosis bacteria are intracellular pathogens and primarily infect macrophages, and these phagocytic cells are also used to analyze the virulence of M. tuberculosis strains and mutants. When M. tuberculosis enters the body through the nasal or oral cavity, the body fails to defend against the pathogen, so the microbial disease progresses. From the atmosphere, the human host inhales the infectious tubercle bacillus as droplets. This occurrence of bacterial entry activates the innate immune system, particularly on the tracheal and bronchial epithelium, to fight against pathogens. Those bacteria that survive from the first line of defense enter the lungs. Macrophages engulf those tubercle bacilli that reach the lung alveoli. This phenomenon infects the host because some survive but no disease symptoms manifest. When the host isolates the pathogens, the progression of infection leads to the formation of tubercles. The pathogens multiplying in macrophages cause the chemotatic response that results in additional macrophages. This wall of lesion formation gives the name of the disease, and the results of unsuccessful bacterial destruction by the macrophages lead to the release of enzymes and cytokines. This mechanism causes lung damaging inflammation. After 3 weeks of primary infection, the tuberculosis symptoms appear. In addition, many of the macrophages die, in which tubercle bacillus is released, such and a caseous center is created. At this point, many aerobic tubercle bacilli remain dormant. Further, at this stage, the lesions become calcified and may arrest the disease. The next stage where the symptoms of tuberculosis form into a mature tubercle. Next, liquefaction occurs, in which, as the caseous center enlarges, the disease progresses. This mechanism forms a tuberculous cavity, which allows the aerobic bacilli to multiply outside the macrophages. The tubercle ruptures when the liquefaction continues, which allows pathogen to escape into a bronchiole. This occurrence affects the lungs, leading to pulmonary tuberculosis. Tuberculosis is the leading cause of death from a single infectious disease agent and tuberculosis. As shown in the figure, those in blue region in the Americas, European region, as Eastern Mediterranean, and Western Pacific regions had an estimated TB incidence rate of less than 10 per 100,000 in 2019. Therefore, these regions are well placed to target TB elimination. Next figure shows the different countries with at least 100,000 incident cases of TB in the same year, 2019. Thus, TB disease numbers of cases are prevalent in these 8 countries. We have India, China, Indonesia, Pakistan, Philippines, Nigeria, South Africa, and Bangladesh, accounted for two-thirds of global cases. So this table shows the TB disease case numbers and incidence per 100,000 persons by birth origin and race or ethnicity in the United States from 2017 to 2020. By birth origin, the TB disease case numbers and incidence per 100,000 persons for non-US born are greater than US born from 2017 to 2020. While race or ethnicities, case numbers, and incidents vary for the birth origin. The Black, non-Hispanic US born has the highest TB disease case and incidence, followed by the white non-Hispanic group. For the non-US born, Asian group has the highest TB disease case and incidence for 4 consecutive years, followed by the Hispanic group. So M. tuberculosis bacteria are spread through the air from an infected person to another via droplet nuclei. They are transmitted by air in coughing, sneezing, talking, or spitting. These infectious airborne particles are inhaled and non-specifically taken up by alveolar macrophages, leading to tuberculosis when the immune system fails to combat the pathogens. Tuberculosis is the major public health concern globally. The symptoms of this disease are prolonged fever for 2 weeks or more, cough with occasional blood discharge, night sweats, significant weight loss, and lack of appetite, to name a few. Thus, it is crucial to consider proper and accurate management of this infectious disease. One method to determine whether a person is infected with M. tuberculosis is the mantle tuberculin skin test or TST. So this skin test is performed by injecting tuberculin purified protein derivative or the PD and should read the skin test reaction between 2 to 3 days after administration. The test is positive if there is a bump of a specific size where the fluid was injected, then an X-ray is done to make sure of the positive result. So if the patient is positive, a minimum of 6-month therapy is required. Treatment for tuberculosis varies in the regimen depending on the sensitivity of the organism and other factors. Multiple drug therapy includes the first-line drugs rifampin, isoniazid, pyrazinamide, and ethambutol. This therapy is needed to mitigate the emergence of resistant strains. If resistance develops to alternatives, the second line drugs that can be used are aminoglycosides, fluoroquinolones, paraaminosalicylate acid or the PAS. It is also necessary to consider prolonged treatment because the pathogen M. tuberculosis grows very slowly or is ordinarily dormant. So the drug pyrazinamide is recommended as an effective against inactive M. tuberculosis plus antibiotics such as streptomycin, which is the first effective antibiotic for TB treatment introduced in 1944. Unfortunately, problems arose regarding cases of TB that are caused by multi-drug resistant or the MDR strains. These were resistant to the first and second line drugs, leading to extensively drug resistant XDR, in which they were untreatable and emerging worldwide. A range of new treatment regimens has emerged to fight M. tuberculosis and mitigate the infection of this pathogen. This comparative studies conducted by De Grotta et al. Evaluated the efficacy of experimental drugs against Mycobacterium tuberculosis using mouse models. The bacterial infections were observed in the lungs and spleens of the mouse models and were evaluated every month. Drug regimens were compared using three mouse models: a high dose aerosol or the HDA, a low dose aerosol or the LDA, and intravenous or the IV. The control group had the standard drug regimen for 6 months, where the intensive phase of 2 months of isoniazid or INH, rifampin, RIF, and pyrazinamide or the PZA, forming the HRZ drug regimen, followed by a continuation phase of 4 months of INH and RIF combination, forming the HZ drug regimen. In the experimental groups considered two new drug regimens, the first experimental group or treatment one used moxifloxacin or MXF instead of INF plus RIF and PZA, forming the MRZ drug regimen for 2 months. And the last 2 months is the combination of MXF and RIF, forming the MR drug regimen. And the second experimental group or treatment 2 used the combination of RIF and PZA, forming the RZ drug regimen for 6 months. Figure 1 shows the comparison of HDA, IV, and LDA infection models in mice treated with different drug combination regimens. Graphs A, C, and E are the bacterial numbers in lung mice after a high dose aerosol infection, intravenous infection, or low dose aerosol infection with M. tuberculosis for 6 months drug treatment. After 2 months of treatments in the lungs, the graphs show similar reductions in bacterial loads of the three drug regimens for the three infection models in mice. Among the three models, the treatment 2 had the greatest bacterial colony compared to the control and treatment 1 groups. This means that treatment 2 is significantly less effective than the control and T1. The efficacy for both control and treatment 1 drug regimens are comparable in all the three models. Only in the LDA group, specifically the treatment 1, showed a significant improvement in treating the infection at 1 month, but this is insignificant compared to the control or the standard regimen. After 4 months of treatment, mice treated with either the control or treatment 1 showed no detectable colony forming units or the CFU in mice lungs. On the other hand, graphs BDF are the bacterial numbers in spleens mice after high-dose aerosol infection, intravenous infection, and low-dose aerosol infection with M. tuberculosis for 6 months drug treatment. As shown in the graphs, spleens responded to a similar trend to the lungs. The T2 was again less effective than the control and treatment 1 after 2 months. The mice from the control and T1 did not show any detectable bacterial growth in spleens after 4 months, while treatment 2 still had detectable colony forming units in mice spleens. Table 1 presents the viable M. tuberculosis in lungs and spleens of mice 3 months after cessation of treatment with three drug regimens via the HDA, IV, and LDA infection models. Considering the HDA infection in the lungs, the data shows that T1 has fewer mice detectable with CFU than in control or 5 months treatment. The same trend is observed in the relapse rate between these regimens. However, these regimens have a comparable effect on the spleens. For the IV and LDA infections for the lungs and spleen, same trends are presented on the data table, plus the relapse rate, whereby T1 is significantly less than the control. After the 6 month study, the infected mice treated with MRZ and MR had a significant effect against M. tuberculosis, which was undetectable after 4 months of treatment. Based on the results, the scientists concluded that the experimental drugs used have the potential against M. tuberculosis. So, to prevent severe infection of M. tuberculosis leading to pulmonary tuberculosis and other complications, it is necessary to consider the following. First, if symptoms persist, consult your doctor and adhere to the treatment plan around 6 months of taking drugs for the treatment. Next, comply with the necessary preventive measures like wearing a mask, covering the mouth during coughing or sneezing. Third, we have here keep good personal hygiene. Do not spit on the floor or anywhere else. And last, live a healthy lifestyle, avoid smoking, liquor, and eat fruits and vegetables, and consider also exercise. Tuberculosis is a contagious disease and one of the top 10 causes of death worldwide, caused by Mycobacterium tuberculosis discovered by Robert Koch. A unique characteristic of the M. tuberculosis, which suggested its taxonomic classification, is the genus name Mycobacterium, uh, which forms a mold-like structure where myco means fungus. This bacteria progress considering the different stages to cause infection when the infected host is susceptible. The pathogen has the portal of entry causing primary lesion, and some will be considered latent tuberculosis, leading to post-primary tuberculosis, resulting to pulmonary tuberculosis. In 2020, the World Health Organization reported that the microbial infection was prevalent to Asian countries, and the pathogen is airborne through droplet nuclei from person to person. The treatment for tuberculosis varies in the regimen depending on the sensitivity of the organism and other factors. Generally, multiple drug therapy is used at least 6 months. This therapy considers first line drugs and second line drugs. Moreover, the related study presented using MRZ and MR drug regimens has the potential to treat bacterial infection in a shorter time than the standard drug regimen. Indeed, it is crucial to know the symptoms and ways to prevent TB because, as we know, prevention is better than cure. Okay, to check for understanding, the post-assessment will be administered. So same test will be given to evaluate the teaching learning process and determine how much each one learned about the topic presented. So here are the references. Mahalo.